Morning everybody. Shall we crack on with the safety briefing? First patient is Mrs Jones, having an open hysterectomy.
Shall we start with the introductions?
I think I know everyone. Okay.
I'm Shobha, I'm the scrub nurse.
Yvonne Obson, gynae consultant.
Caroline, ODP.
Jill, anaesthetics.
I'm Brodie, recovery nurse.
I'm Jerry, I'm the new scrub nurse. It's my first week.
The first patient is Mrs Jones, who's 45 years old, and she'll be having an open hysterectomy.
Yeah, she's normally fit and well. I don't anticipate any particular problems. Endotracheal tube, and she'll have a PCAS afterwards.
Yeah, so the F1 Jess called me just before I came down. The bloods aren't back yet. She sent them to the lab. They can't find them on the system. Apparently she's just sent down some more, but they're going to be 45 minutes before they get back. I'm not happy to proceed really without clotting screen, gluten save. I think there's a fair risk of hemorrhage. Is there any chance that we can move the list about?
That's fine, we'll move Mrs Jones to second on the list. That leaves us with Mrs Ross, who is first on the list. She's 33 years old, her BMI is 44, and she's in for a DNC.
I thought she was for evacuation of retained products.
Yeah, that's right. It's just a different name for the same procedure. But thanks for pointing it out. I think it's really important that people speak up if they're not sure what's going on.
Well, if her BMI is 44, then I think probably we should have a longer speculum.
The last patient will be Anita Davis, who is a 60-year-old lady, and she'll be having a hysteroscopy.
Yeah, she has mild asthma. No major issues from my point of view, just a laryngeal mask.
It also says on the list she's hard of hearing. But how hard of hearing? Will she be coming down with her hearing aids?
Good point. Yes, we need to see about that because it's going to be important when we're checking her allergy status and identity with her. And obviously in recovery, if we're asking her to open her eyes and she's not responding.
Right, so if you'll phone the ward, then I guess we are all sorted. So anyone's got any questions? No? Right, thanks so much everyone.
Oh, no, hang on a minute. There is something actually.
Hello? Yep. I can't do it now, I'm in theatre. Speak to you later. Bye.
Jerry, you were saying?
That's gone.
All right everyone.
It's not at all cheeky for the scrub nurse to take over from the surgeon during the briefings. It's in fact it should be encouraged really because it allows the nurse to interject and give information. It is all about sort of allowing everybody to have a say about the things that happen in the patient in the perioperative briefing. You want all members of staff to interject and give information about all the things that might affect the smooth passage of the day really. You don't want people to go away from the briefing having a misunderstanding or having information that could have contributed to the safe conduct of the day. Everybody there has an opportunity to voice their concerns, voice their opinions, and in order to do that everybody has to know who everybody is and what their role is. And that's the only way of getting everybody in the briefing to really interact together. And so that introduction at the beginning of the briefing is paramount to the way the whole day goes. And it should not be skipped over at all during the briefing. If it is, then you find that people don't speak up. The scrub nurse in the scenario interrupted the surgeon during the briefing to clarify the operation and intimated that they might have been doing the wrong operation. Should the surgeon have been cross with the scrub nurse? Well, clearly not, because that's a really important issue to bring up. There was misunderstanding between what the operations were. They're clearly the same operation, but with a different name. That idea of getting the right mental model about what's going on is really important, and so it's very important for people to speak up in the briefing and talk about what the misunderstandings might be and raise any issues. And if you want people to raise their safety issues, you have to get them to speak up at that time. And it's all about generating the same mental model that's going on. If the surgeon had been cross with the scrub nurse, then what do you think would have happened? Probably that they would have shut up, and the next briefing they wouldn't have said anything, and then that relationship would have had a steep authority gradient.
Hi, it's Caroline, ODP, phoning from Theatre 1. We've got Mrs Davies next on the theatre list. I'm just calling because she's hard of hearing and she's coming for surgery, so we need to make sure, please, that she has her hearing aids in. Yes, great. Thank you very much. Bye.
You saw the ODP on the telephone using a communication pattern. This is essential for good communication, really, and it's making a communication brief, making it very efficient, and making sure you get all the points across. There are various packages that people can use, but there's the package of SBAR, which stands for Situation, Background, Assessment and Recommendation. And this sort of pattern, if you think of those four things in your mind, when you're making a phone call or any communication, it gets the message across and the recommendation and what you're going to do about it very quickly. So it's essential that you have some package. If the more people that know about it, if the person at the other end of the phone or the other end of the communication is aware of that, they'll be waiting for that next bit. And they'll be saying, well, what about the recommendation? So if you're both using it and learn to use it, communication becomes very effective and very efficient.
Are you wanting some CDs for this next lady?
Just a fentanyl, please.
Okay. Oh, and by the way, do we have an actual weight for her if her BMI is 44?
135, I think.
Oh, well, that's just great. She's too heavy for the table now. I'm going to have to postpone while I phone round and try and find the right table.
That is exactly what I was going to mention earlier to Yvonne. A phone rang and it completely slipped my mind. I'm sorry.
The problem with phone calls and interruptions like that is that they do take away the flow of the briefing and you lose questions. However, it could have really contained some important information that could have been relevant to the briefing that was about to take place. For example, it could have been a blood result about a patient. It could have changed the order of the list. So you have to take the phone call in these briefings and take those interruptions. The real trick of a briefing is to then control the interruptions that take place. And so whoever's leading the briefing or those involved in it have to say, hold on a minute, we've had an interruption. What we need to do now is go back to where we were so we can retrace our steps and we don't lose the information we were about to change. And sometimes it'll come back to them. And in that case, if you're taking it back to the beginning of the briefing, so let's discuss that patient again, they probably would have brought out the point that they missed that became so crucial later on. When you're doing a briefing, there's a whole team of people in the briefing, but there's a bigger team of people involved in this, and the communication across that bigger team is paramount to patient care in any setting. It's important that we appreciate the work that goes on perioperatively, or preoperatively especially in this case, on the ward. So all the nursing staff and all the junior doctors and the FY1s on the ward doing all the work to get the patients ready for theatre is really, really important. And it's really important they communicate any information that could be relevant to the patient's care to the briefing when it's taking place at the time. And so, for example, the FY1s doing blood results, if they come across blood results that are abnormal, or if they haven't done them, or they're delayed, or whatever the case may be, the briefing people need to really to know that. It's really important they can pick up on this information because it's going to have a relevance to what we do in theatre and the timing of the theatre. The last thing we want to do is send for a patient, find they're not ready, or get them to theatre and find that we can't do the procedure because that wastes even more time. It's upsetting for everybody involved.